Elizabeth and Robert Marr died of COVID-19 within a day of one another in Seattle. They would have celebrated 50 years of marriage in August, but their deaths at the end of March were not the same. Liz was a vivacious matriarch at 72. She died after 2 weeks, sedated on a ventilator. Her analytical engineer husband, Robert, 78, chose no aggressive measures. He was able to communicate with their adult children until nearly the end. And this is really some of the flavour of the topic today. We're very pleased to have with us today as expert speaker, Dr. Daren Heyland. Daren is a critical care doctor and a professor of medicine at Queen's University in Kingston, Ontario. He also serves as the director of the Clinical Evaluation Unit at Kingston General Hospital, which functions as a methods centre for multi-centre clinical research. For over a decade, Daren has chaired the Canadian Researchers at the End of Life Network, which has a focus on developing and evaluating strategies to improve communication and decision-making at the end of life. More recently, he has developed web-based tools to aid lay people, like me, in decision-making related to serious illness. The Plan Well Guide and the My ICU Guide. Daren has published more than 400 peer-reviewed papers, raised many hundreds, 150 million and more in external grant support, and given more than 350 international presentations. Daren is with us today from Calgary, and as I said when I got on the call with Daren, it's very impressive that we have shirt and tie this morning at 5 a.m. in Calgary. Thank you very much for being with us today, Daren, and please take the floor.
Thank you, Jane. Thank you for that introduction. I really appreciated the cases that you shared too about those older persons in Seattle that passed away, because it really illustrates some of the variability and the experience that people have. And I want to talk about that as I mature this subject about COVID and older persons, a threat to person-centered care. But perhaps I could define for us what I mean by person-centered medical care, where we're talking about the practice of caring for people and their families in a way that are meaningful to that individual. The Institute of Medicine defines patient-centered care as, quote, providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that the patient values guide all clinical decisions. It also might be helpful to sort of contrast that with other models of care. There may be more provider-centered care where it's more about the healthcare provider, and typically the doctor focuses on the diagnosis and the potential treatments, and the issues that the patient brings to the table is a little bit to the side. We've also observed during COVID more of a healthcare center model of care, where what's important to the healthcare system is what's driving treatment priorities. And again, the patient's values, preferences, and needs are somewhat marginalized. So I think those are important distinctions as we move forward in this conversation of the relationship between COVID and what's happening to older persons. But I actually want to start with an anecdote that takes us back to more than 20 years ago when I was just starting out as a critical care doctor. I came to work one day and there was a middle-aged man with a placard, with a sign, walking up and down in front of our hospital saying, "You killed my mother." And of course, this was very distressing to me and to others that worked in that intensive care unit. And we powwowed together as colleagues and discussed the case. And I won't go into the details about the case, but what emerged from that discussion of the quality of care that that older person received was, well, how do we know how well we are doing as an ICU team in providing care to these frail, older, vulnerable people. And the question was, we didn't have a systematic solution. And so that incident began more than a two-decade career interest of mine in not only caring for said patients as a clinical doctor, but as a researcher, trying to figure out how to systematically measure their needs and bring that voice of a vulnerable population to the table, where we're discussing how can we improve the quality of care that we provide to older patients. And that's what led to me developing the CAN Help questionnaire, which is a patient satisfaction, family satisfaction measure that is specifically designed for older persons in our healthcare system. What was their experience? How satisfied were they in their journey? And a very important piece of that work was when we surveyed hundreds of older persons in hospitals, in many hospitals in Canada, and we asked them, well, how important are these various items, and how satisfied are you with the same items? And by juxtaposing importance and satisfaction, we're able to highlight the things that these people and their families were saying are most important to them, and they were the least satisfied. So it helped us prioritize the things that we needed to address for this patient population. And without going into details, let me say that the signal pointed towards aspects of communication, clinical decision-making, and relational aspects with their supervising physician. You can imagine these being a very vulnerable patient population, and having trust and confidence in the clinical leader looking after them was super important. And so keep that in mind as I now, want to share with you three anecdotes from the literature, from the medical literature, research findings that were conducted before COVID. So this is data from before COVID, where in the first instance, we would go into hospitals in Canada, and a researcher would spend usually upwards to an hour with these older persons in hospital, and we would interview them. We would define for them, using more rigorous methods, what their authentic values and informed treatment preferences were. And then we would go out onto the medical ward and look at the chart and compare the preference articulated by this older person to the medical order for the use or non-use of life-sustaining treatments in hospital. And guess how many times they actually agreed? 1 out of 3, meaning 2 out of 3 times there was a discrepancy between what we elicited by talking to the person and what was actually ordered on their medical record. And so we define that as a medical error, where someone's prescribed or set up to receive potential use of or non-use of life-sustaining treatments when it was against or not consistent with the wishes of that older person. The majority of the error centered around the use of cardiopulmonary resuscitation, or CPR, at the end of life. So older person saying, no, that's not really what I'm up for. And yet they were ordered that on their medical record. So I use that as one illustration of perhaps a lack of patient-centered care. And again, this is pre-COVID. But another example would be a study where, let's say a decade ago, it wasn't so often that we would see octogenarians or older than 80-year-old persons in ICU. It was unknown to us what the prognosis or the outcome of the very older persons might be in the ICU. So let's follow these patients for a year. And so we recruited over 600 older patients admitted to ICU, and we followed them for a year. Now, of course, they're too sick for us to interview, so we enrolled their family members as proxies, and we evaluated with them the values and the preferences and the issues. And what we learned from talking to them was the main governing value driving medical treatment decisions was comfort measures only, that we should be focusing on comfort. And the irony was, of course, that, well, these are critically ill older persons on mechanical ventilation being supported with life supports in ICU, many who actually died after 10 to 12 days in the ICU, when the governing value was comfort measures. And so that again highlighted a contrast between what people saying they want and what was actually being delivered. And families, when we measured family satisfaction with the intensive care, they were most dissatisfied again with communication and decision making. Another piece of work by colleagues in the United States actually audio recorded the family conference where those goals of care are discussed with patients' families, because again, the patients were too sick to participate in that. And what we learned from listening in on those audio recordings is again that the use of patient values and preferences to ground those medical decisions on those values and preferences only occurred 8% of the time. So they weren't the topic, they weren't the foundational aspect of medical decision making. So what I'm trying to say is that even before COVID, we have illustrations in acute care hospitals, at least in North America, if not worldwide, where poor communication, poor decision making leads to medical error, where people are being signed up for medical treatments that they didn't really want in the first place. And I can imagine that with COVID, that's only been made worse. I don't know that we know this yet because the medical literature is still evolving, but we do know that COVID-19 is a disease of older persons, that more than 90% of people who contract severe COVID are older. If you're over 80 and you end up developing severe COVID disease where you end up on mechanical ventilation, you've got a 90% probability of dying. And even if you survive, that would take 2 to 3 weeks on average of being in an ICU on mechanical ventilation, and then many, many months afterwards recovering. And we know from, again, pre-COVID, that if you have this sort of prolonged critical illness and you survive, you're going to have a lot of survivorship issues. You're going to have significant impairments to your physical, psychological, emotional, mental well-being. And for many of the very older, I've heard them say to me, well, I would rather die than have to go through all that. And whereas others may want that kind of effort. But the key issue here is providing person-centered care, that we're making foundational clinical decisions on what's important to the person, and that we're eliciting the values and preferences in a way that can inform those medical treatments. And I guess that's my point, is that for whatever reason, the system doesn't really respect those issues, and it's not happening. There's a lot of medical error. So what can we do about that? And I guess the one thing that I've been focused on lately is more about empowering people to take matters into their own hands, if you will, and to give them the knowledge to navigate that clinical decision-making space. So rather than be a passive vehicle in a very complex, healthcare system, and of course, healthcare systems vary around the world, but at the core of medical decision-making is a doctor and a person, whether that be the patient, him or herself, or because they're too sick, we call her usually a family member or a legally named substitute decision maker to come together to make clinical decisions. So what I've been trying to do is improve that process of clinical decision making. And we can improve it a lot by making some of these decisions, or sorry, not making decisions, but planning for or preparing to make some of those decisions in advance. And so that's what the essence of Plan Well Guide is. And I'll say more about that in a second, but I just want to back up and emphasize a point that you might expect that, well, why doesn't the doctor, do this or do this better? And we surveyed over 1,200 doctors and nurses working in Canada and asked them, how come you don't more fully engage persons in hospital, typically older persons with chronic or life-limiting disease? How come you don't engage them more comprehensively to have these sorts of planning conversations? And they raise the issue that these people are too ill prepared. They don't know enough about the terminology. They're not ready for it. They're not accepting of the realities of their condition. And so it really pointed that we needed to focus on preparing the person if we wanted to reduce those barriers, to have the doctors come in and more fully engage with their patients and or families to make better medical decisions. The other issue that our research has highlighted is that unfortunately doctors don't use optimal language or communication strategies. And so you think it might be as simple as saying to the person, tell me what's important to you. But when a patient sort of answers that open-ended question, the doctor has to make a translation of that answer into a medical order for the use or non-use of life-sustaining treatments. And right now that's a very non-transparent, irreproducible process. Or said differently, the science has shown that you ask 10 you give 10 doctors the answer to a values, open-ended values question, and you can come up with 10 different prescriptions for the use or non-use of life-sustaining treatments. And so I'm highlighting one of the features of Plan Well Guide, where we've tried to make that decisional process very transparent and reproducible, so we can reduce the risk of medical error. I want to make a shout out too for lawyers, because I do believe that in most countries, lawyers are involved in the legal naming of substitute decision makers. So there's an interaction that they have with their clients and my future patients. And they're talking about this advanced care planning or thinking ahead, planning ahead for future periods of incapacitation. And usually there are forms where they're naming that substitute decision maker. Unfortunately, they go a little bit too far, and they start to pen in those legal documents instructional directives. Things that the lawyer thinks are important to the person are actually codified in these legal documents as instructional directives, as if I'm supposed to follow those. And I just want to communicate that those are not only not helpful to me as a doctor, but often in different provinces or states or countries, they're not even ensconced in healthcare law. What I'm legally obligated to do is to obtain informed consent from either the person or their substitute that has been named by those documents. And so I have to go through a conversation about explaining risks and benefits and treatment options before I can actually make a medical decision. And so those instructional directives, where they were made at the kitchen table of a person or in a law office with a lawyer, of course, there wasn't that rich discussion of of options. And so I can't really believe that decision has any validity now when I'm now facing the person who has a complex medical problem. And so I have to set aside that instructional directive and really just deal with the substitute decision maker. So what I'm trying to say is I'm not advocating that we make medical decisions in advance. And that might be a prevailing idea out there for those who are knowledgeable about advanced care planning, I'm not advocating that we make treatment decisions in advance. I'm advocating that we prepare people to be able to articulate their governing values and their informed treatment preferences, so that when they or their substitute decision maker have to come together with a doctor to make a medical decision in advance, then they're prepared. They're able to voice what is useful to me as a critical care doctor to hear in order for me to make a transparent and reproducible decision about whether life supports is right for you or not. So I hope that was helpful in terms of introducing the problem. Just to say it again, that in modern day medicine, unfortunately, there is a lot of medical error being committed, where patients are being prescribed aggressive, intensive treatments that are not consistent with their authentic wishes and informed treatment preferences. And whilst we could talk a lot about the system and the doctors and how they need to change and it needs to improve, my focus has been more facing lay people and saying, hey, how can I empower you? How can I educate you? How can I capacitate you with the tools so that you understand shared medical decision-making, so that you can authentically express values and inform treatment preferences. And that's what the essence of Plan Well Guide and My ICU Guide are tools for people in the one instance and families of critically ill patients in the other instance to understand the decision-making world and to be able to better prepare for their roles in clinical decision-making. So one of my objectives, obviously, is engaging people like yourselves who function in that advocacy role, or who also are people who perhaps are older yourself, or perhaps have older parents or even grandparents where this is relevant. And so by chatting with folks about it and explaining the problem and these potential solutions, hopefully we can move this agenda forward and get people more prepared for when serious illness hits, like COVID-19. So I'll pause there and be happy to discuss these things with you and take any questions.
Look, thanks very much, Daren. And there were a number of questions coming in, but some of the words that you mentioned, you know, this survivorship issues, you know, that, and I think that it would be helpful for you to just unpack that a little while I call on Jackie, Dr. Barley, and Jane Teasdale. So perhaps you can actually just unpack this phrase, survivorship issues.
Sure. I mean, we used to be happy when an ICU patient would come in and they were critically ill and we apply our technologies and we save a life. But then we realized that survivors have significant burden. If you're sick, you're lying in bed, you're very catabolic, which means there are processes in your body that are eroding your muscle. You emerge very physically weak, very psychologically distressed, even having symptoms of post-traumatic stress disorder, anxiety, or depression. And those can last for years. And so for an active, healthy 50-year-old to have a 3-week course in ICU, they're gonna, you know, they're gonna have a struggle to get back to how they were. So imagine what that's like for an 80-year-old who already starts frail and who is just sort of barely hanging on to their independence. And again, I've heard it many times when an older person would say, well, I would rather be dead than be like that, or to have to go through that. And so they would express a preference for just, you know, medical treatments that focus on comfort measures only. So we're learning a lot more about the survivorship burden. We're actively doing research to try and improve the survivorship experience. Again, unfortunately for older persons, they don't typically make it into randomized clinical trials. And so we don't know the application of a lot of medical knowledge to that older person, but we are learning more about that survivorship burden so that we can better describe it on average to patients to help them make informed treatment decisions.
Thank you. I'll call on Jackie, Dr. Barley, and Jane Teasdale. So Jackie, are you on the line? Are you on mute, Jackie? All right, so.
Okay. It's,
okay.
It's an example actually from my work with persons with severe language disorders, aphasics. Okay. And I think it has relevance for what you're talking about, and not only for the severely ill persons, but also for the family. Because I always hear that when patients are released from the hospital with a severe language disorder and hemiplegia and other things, that they're not told anything about, you know, what they should do or whatever. They're not informed. But the point I want to really make is that at a conference, one of the very famous speech and language pathologists, Laurie Holland, showed a video of a young physician interviewing a client with aphasia, severe aphasia, and he got nothing out of that patient. Then this physician, young doctor, received training in interview techniques, and he went back and interviewed the same client again, and it was 100% difference in what he could learn from that person. So I think it's very, very important what you're saying, patient-centered, but also that the physicians really have to learn how they're confronted with a person. They have to deal with that person on a one-to-one basis, but they should have also a little more training in really how to do that. I think it would be, you'd gain so much more from an interview with the family, or even if a person is severely impaired, if you know how to do it.
I mean, I appreciate the comment and appreciate the endorsement of the idea that clinicians need better or more training in communication and decision-making skills. Absolutely. And as one that spent, more than 2 decades involved in medical education, trying to train doctors on the language of shared decision-making, I got discouraged and I moved away from that, because it's like beating your head against the wall. It's not a topic that's important to doctors. It's not a topic that they're held accountable for in their medical exams or their competencies. There's not, at a system level, there's no quality indicator or measure of performance or job satisfaction that this is measured so that they feel like they have to step up and improve. And so my only recourse was to sort of pivot a little bit and say, okay, if I can't influence how doctors in the system, value this competency, I better go to the other side. And they also tell me that one of their barriers is lack of patient preparedness. So I pivoted and I went over here and I said, okay, let me help upregulate the other half of the team and see if they can, drive the quality conversation. Unfortunately, maybe you'd say I'm being a little bit negative, but it's my lived experience of trying to influence the system, trying to influence the doctors, that was not as successful as what I'm finding right now is a tremendous receptivity from people to learn this stuff. I think historically they'd been a bit too passive, bit too trusting, and so they just go into illness and expect it to turn out okay. But I'm trying to message that, no, you need to advocate. You need to advocate for yourself. You need to prepare your advocate, your substitute decision maker, so that they can advocate for you to make sure you get the medical care that's right for you.
So, Dr. Heyland, just before I ask Dr. Barley to talk about his issue, I just want to put it back to you. I've been in the situation of trying to help parents navigate systems, but they don't quite know what question to ask. They don't quite, so I guess the Plan Well guide sets it out quite clearly for us. So would that be correct?
Yeah, it's not only so in Plan Well guide and My ICU guide, not only are we asking the right questions, but we're asking it in the right way. And if I can just use an anecdote to illustrate the point. Frequently when I would be engaging often a daughter of an older person to help me understand, what mom would have wanted when we're talking about using or not using or withdrawing life-sustaining treatments. Someone might say something like, well, my mom was a fighter. She'd want every chance possible. And so a doctor might take that statement and infer, therefore, I should prescribe or continue to prescribe life-sustaining treatments. But what we found through our research is people don't understand the consequence of that expressed choice. And so they don't realize that if we push harder, we push longer for a longer life, that we do so at the expense of quality of life, that those are competing ideas. It's a trade-off. And so if you look into the guides that we've created, we're asking the right questions. Are you the kind of person that, favors prolonging life or the focus on quality? But we ask it in a way that the person answering the question sees that they can't have both. They have to go this way or go that way. Are you the kind of person that prefers a natural death? Are you the kind of person that's okay with the use of technology at the end of life? And so again, you can't have both of those. And we ask it in a way that people see the competition. I hope that was a useful.
Yeah, no, that's very useful. Dr. Barley, would you like to pose your question? Just you're muted at the moment. We still can't hear you.
Very good afternoon to all of you.
Perfect.
Dr. Daren, sir. It was very enlightening talk, and I'm a practicing geriatrician here in India. Uh, I'm happy that I learned from you. There's a decision on patient-centered care. Now I have a support from you because I practice. What I do is when a patient attenders come to me and ask, "Is a case of non-Hodgkin lymphoma didn't? Shall you go for chemotherapy?" My first response is, you ask the old man, does he wants to go for chemotherapy or no? So I am in favoring the patient-centered decisions rather than just because they offered to go for a higher center, take a chemotherapy, paying huge money and come back and the patient remains bedridden despite that. So when I tell them, they will take it, you ask the old man, does he wants that? And after 15 days, we get a very good feedback. Sir, your advice was very good. So that old man didn't want the pain and the associated complications of chemotherapy, and he wants to be happy. Yeah. And second main question that I wanted to ask you is about what about the elder abuse that as a clinician, we are not trained. I'm also a physician, a geriatric physician. After doing my geriatric medicine, I was aware that what elder abuse means and how to identify and how to manage them. So elder abuse is on rise even in the nursing home and even after care. What we see in my setup is the patients who go out of ICU as in congestive heart failure or those who remain dependent on the caregivers, they are abused in the home as well. So can you throw some insight on this? Can you share your insights on this, sir?
Okay. And Daren, we'll just take Jane's question, Jane Teasdale, and then you can answer both. Jane? Okay. Are you there, Jane?
I am. Sorry.
Okay. That's all right.
Just taking it off.
Okay.
So thank you for your topic today. It's very important topic, I think. So I think, you know, person-centeredness is really knowing what the person wants towards the end of life. So thank you for explaining that. And I think bringing the person into making decisions about their life, which you had spoken about. And I think the current situation is showing that these are important. Person-centered is important, and to bring forward advanced care planning into the care, it needs to be a culture. And I think, you know, probably within the hospitals and long-term care, we need structures in place to implement person-centered care. And again, it is a culture. And I think, as you explained, it is very difficult. Person-centered care is very complex. Mosaic has actually worked on the last 5 years on implementing a person-centered care process, which we have done. But I can say it's a lot of learning and very complex. It's putting all the pieces together and really enforcing personal support workers and our team in implementing person-centered care. I also think, you know, we accept the current situation right now is difficult, but how do we allow for families to be there at the end of life for those people who have COVID-19 and are at high risk of dying? We do not mean being there at the last hour or two, but being there for the substantial period of time. If you are in long-term care home and have a severe cognitive decline and any other medical conditions, the risk of death obviously is very high, in which you had mentioned. Yes.
Look, thank you, Jane. If we can keep the questions short, and that will help. We've got a few banked up, so thank you. Dr. Heyland.
Okay, great. Some great questions from my colleague from India. I'm not going to offer much insight on elder abuse. That's not my area of expertise. I did appreciate your anecdote about, you know, ask the person about their wishes when it was in the context of deciding about chemotherapy. I do want to make a point that our research has shown that too often we make assumptions that the person or the patient is a knowledgeable consumer, and that it's as simply as asking them, what do you want us to do? Like, as if they can just verbalize, you know, their the wish, and we should follow that wish. And although at face level, that sounds like what we should be doing and is consistent with patient-centered care, when you go a level deeper and you interrogate people as to their understandings of the risks and the benefits and the possible outcomes and options, they don't have that understanding. So for example, we go into hospitals, we ask people what they know about cardiopulmonary resuscitation, what they know about the process of care, the outcomes of care, and they have no clue. And yet we go to their medical chart and they're signed up for CPR. So they bought a package that they had no idea what the process or the outcome was, because we treated them as an autonomous person that should be able, if we just ask them and they tell us, oh, okay. And so I'm trying to dispel the myth that simply asking people is the solution. It's way more complex than that. And it speaks to a role of what we call decision aids, medical decision aids. And again, Plan Well Guide is an example of that medical decision aid, where we're explicating the risk, benefits, and options and outcomes of the difference between going to the ICU or staying on a hospital ward and receiving medical care or receiving comfort care only. And so part of my initiative is to better inform people, what these different treatment options are, so that when they say, I want CPR, then they really know what they're getting. We've got a 7-minute video decision aid on CPR, for example. Again, my issue is that we have these materials, we have these decision aids, but they're not embedded into the healthcare system. And so people don't get exposed to it. And doctors keep asking the question, well, when your heart stops, do you want us to resuscitate you? And what's an older person who doesn't understand any of this supposed to say other than, okay. And so they get signed up for CPR. And so that problem perpetuates itself. I mean, Jane, you spoke a lot about culture and the importance of, creating systemic changes and processes to support that patient-centered care. And again, I want to, highlight that part of that has to be, decision aids that pre-decisional encounter before the patient-person substitute meets with the doctor to make medical decisions. How do we embed into our workflows, whether we're talking about acute care or long-term care, that there's some capacitation experience for that person so that they and their substitutes are more ready, more prepared to make decisions about, if I got sick, should I escalate and go to an ICU? Should I go or just receive, palliative care? I also want to pick up on your comment about the family, the role of family visitation. I'm horrified by what I'm hearing and seeing in how people are dying in these under COVID circumstances. And I understand the why, that the system had to protect itself and its workers, but at the expense then of these older persons who die in isolation. Here's a quote from a colleague of mine who said, the tragedy, while it's a tragedy that many older persons are dying, I am concerned about the way they are dying. After being caged up for days to weeks in an ICU bed, people died in isolation without seeing a recognizable face or hearing a familiar voice. Their hearts drummed its last beat in solitary confinement. Dying alone, that's the real tragedy. And how again, there's a understanding about why it happened, but how can we reimagine how to both protect the system and the professionals, but not allowing that to happen? That takes some creative thinking and some resources, I know, but how's that going to happen unless, we collectively advocate for the vulnerable older person and say, hey, we can't let that happen again. How do we enable those basic rights of having, someone that you love be with you through the care episode, even up until the end?
Okay, thank you. We have 3 more questions, and that may take us to 7:50. So Francis Wilkinson, Hava Bugaje Glitman, I'm sorry for my pronunciation, and also Bruce West. So Francis?
Yes, I'm here.
Welcome.
Yes, very interesting talk. I just will say I've taught a course at Ryerson actually to older people about these very issues, and there's a lot of interest in learning about it from the older community. So it's not, older people are aware of these problems. One thing I wanted to raise that is not what my comment was about was that doing that, I discovered increasingly there are a lot of older people who are alone, and we can't forget them in this planning. We talk a lot about families, but many older people don't have families. And we need to think about that too as we come up with ways to make people aware of these problems. And the comment I made, which is just a quick one, is that in Toronto, emergency doctors seem to be very surprised that no one has been showing up in emergency for other problems, meaning heart attacks and so on. But anyone here who goes to a hospital really feels that they have to have an advocate if they're going to go, someone who's going to stick up for them and make sure they get this kind of patient-centered care. And of course, during COVID, you had to drop the patient at the door and you might never see them again. So I think that has been a huge concern here, and there hasn't been very good communication to the public about what they should do or when they should come in. And it's just a comment.
Okay, thanks, Frances. I will just move on to Hava and Bruce and then give the floor back to you, Dr. Heyland. Hava?
I wanted to ask, often the patient arrives at night, he's in distress, respiratory distress. Maybe he left a will that he refuses CPR, but it's not available. You just put him on the machines, you give it, and in the morning, the family comes and says, so he himself, if he's in better shape, he says, I didn't want it. So what are you going to do? And I just wanted to add, I myself a physician. Physicians very often refuse to go to hospital, or they refuse the treatment because they know very well what expects them. So, but some people just do not know. I don't know how to tell them.
Okay, thank you. That's a prickly question. So Bruce West, and then we'll take it back to Dr. Heyland. Bruce?
Thanks very much. Our first response during this time of COVID for people in long-term care settings has been to shut those facilities down to prevent family members, other caregivers from being able to enter those places. And I think there's been a lack of recognition of the important role that these people play in certainly the quality of life of people in those settings, but even as advocates and even in providing care. When we see the issues that have come out of Ontario with the kind of horrid situation that people are in, I don't think that would have happened if family members had been able to be in that facility, to see what was there, to be able to advocate for change, and even to take some of the burden off of the caregivers, the personal support workers, the healthcare aides in those settings. So I really appreciate what you said, Dr. Heyland, and your perspective, because I think it's important to balance the clinical aspects to the personal aspects in those settings.
Cool, thank you. Let me pick up on what Bruce just said there, because it strikes at the heart. My father-in-law was one of those older persons who was locked in his facility, and he was still quite functional and able to get up and go, but for 2 weeks he was locked in his room, and all that we could do was go in and take him out. And I know there's lots of issues about removing people from long-term care centers, but he was more physically able and just needed a different place to live. And so he's been living with us for the last 2 months. And we've had lots of conversations about how do we balance these risks. Again, a system level perspective leads one to think about stopping the transmission, reducing the risks, shutting everything down. A person-centered perspective allows them to participate in that risk mitigation, risk decision. Maybe an older person would, allow some level of risk of an infectious disease so that they can still function and enjoy a quality of life. Or maybe they could follow protocols that enable them to minimize that risk transmission while still having the latitude of getting in and out of their facility or having people coming in. We just have to re-engineer the way we think about this that provides that balance, I think the word you use, Bruce, and not just have that whole system level focus. And that's, one of my key points today. The other comments were very, let me go backwards in addressing some of them. And system availability of the planning documents is a big issue for us here and even in Canada. And I can't tell you how many times in the emergency room or in the critical care unit, we don't have time to, let alone find a document or talk to a family member to make, we just have to act. And so yes, we sometimes resuscitate first and intubate, and then the next day when the dust settles and we learn more about this person, we're left with orchestrating the removal of those life-sustaining treatments. But I guess I want to make the point that it's less about the documentation and it's more about preparing the person to verbalize. And again, if they're so sick and they're breathing so fast that they can't, you know, hopefully they have an advocate with them who's been able to come in with them, because that person needs to be able to verbalize their authentic values and informed treatment preferences in the moment, so that we make the right decision in the moment. And that's what our research shows, is that we'll make better decisions that are more goal concordant, concordant with the person's values if they're gone through this advanced care planning, medical care planning process. And now just to go back to the first comment, that the older people are very receptive to these ideas. There is a stigma out there a little bit in society about not wanting to talk about death and dying. But most older people, as they move on in life, are more open to that, because they want to control that final chapter of their life. And it becomes more important to them. But I feel like I need to emphasize another point that I alluded to earlier, that what I'm talking about isn't actually planning for your death. The language I use is very precise. It's called serious illness planning. There's a difference between serious illness and end of life. And let me illustrate in a scenario where I was talking to a person about their medical wishes, and before I could even, you know, say anything, she says, "I don't want to die on machines." And I said, "Oh, okay." You know, and she had a very strong, you know, value-laden statement: "I don't want to die on machines." And then I said to her, "Okay, but what happens when you come in and you're really short of breath with pneumonia, and I need to use machines temporarily to get you over that hurdle, and I can get you back out the door how you were?" And then she kind of looks at me, lost that sense of confidence, and says to me, "I don't know, what do you think I should do?" And the point being that when people are planning their death under conditions of certainty, a lot of them will say things like, "I don't want machines. I just want to focus on being kept comfortable." But when I say to them, "Well, actually, I'm not really planning your death. You're going to come in under conditions of uncertainty. You're going to be short of breath. At the point where I have to decide to use machines or not, I don't know if this is your dying episode. I just know that you're seriously ill, where there's a probability that you could die. But there's also a probability that you can recover." And so planning for serious illness is way different. Like, so COVID-19 is an example of serious illness, and it has increased the appetite for many people to lean into this space, by the way. But that's very different than planning your death. If I have stage 4 cancer and I'm on a trajectory and I know that I'm dying, that's a different set of planning, because I'm planning under conditions of certainty. I'm dying, therefore this is what I want. When I see people in the clinic, older persons, I spend a lot of time coaching them off comfort care only, because they think they're planning their death. And I'm saying, no, you're actually quite functional. You're doing well. Why would you forego potentially curative treatments if you got sick? Because you could possibly recover from that. Oh, I could get back. Okay. Because again, the headset is, I'm planning my death. And so I hope I'm not confusing you with that message, but in fact, we're planning for periods of incapacitation when you're so sick. There's a probability you could die, there's a probability you could recover, but we need to know what your authentic values and informed treatment preferences are. This will be the most helpful to us as doctors. And again, if you're too sick, then we're leaning on some surrogate. Yes, not everybody has family, as per the earlier comment, but then that's even more important for them to work with lawyers to get someone, doesn't have to be family, named as their substitute decision maker. And there are professional healthcare advocates as well that can be contracted. Again, this is a fee-for-service kind of model, but there are those healthcare navigators or advocates that could be used in those scenarios too, where there's no family available. So those are just some responses to the questions. Jane?
Muting myself. We're coming to wrap up the session, so I'll just take one more question and then ask you to leave us with, you know, some message. But before I do that, I just want to acknowledge Dr. Yuka Sumi from the WHO, who's on the call, and a wonderful friend and colleague, an international expert, Professor Jean-Pierre Michel. Both of these friends and colleagues are coming from Geneva in Switzerland. So thank you for being on the call. I'll call on Greta Garnis to pose her question. Greta?
Good morning. It's been a very interesting conversation. It's not so much a question as it's something I've observed, and maybe it's just unique to my area, is that many of my relatives personally have written down exactly what they want. And they have the DNR, they have the healthcare proxy, they've told their staff and it's written down and it's in their file. So if something happens, they either pull it up on an iPad or they go to the file. I don't know if, maybe it's because they're more comfortable talking about their end of life, or maybe it's because they're just super organized and practical New Englanders. I don't know if other parts of the world are seeing more seniors writing down exactly what they want, because when the time comes when you need it and make a decision, you obviously can't. So maybe I'm just in a unique situation where we're planning that far ahead and are not that uncomfortable about talking about end of life. Because it sounds like a lot of people aren't comfortable, which is normal. They don't want to talk about death, they ignore it.
Okay, so let's hear what Dr. Heyland has to say. Daren?
And then you want me to sort of wrap up?
Yes, please. Yep.
Okay. So I think in my sort of 20 years or 25 years of professional work, I have seen an evolution in society where we are increasingly more comfortable talking about death and dying. MAID, or medical assistance in dying, has sort of elevated that conversation in Canadian society, at least, if not other parts of the world. But I guess I want to come back to emphasize a point that I'm really trying to pivot a little bit away from planning your death. I'm planning for serious illness. And again, an older person sitting at their kitchen table specifying that I do not want CPR, I do not want mechanical ventilation, has no validity to me when they come in short of breath with COVID pneumonia. Because the context is different, right? The context was, when I am dying, I want this. I don't want CPR. And that's very sensible. It's a very sensible thing to say, but it's not helpful to me as a critical care doctor, because I don't know that you're dying when I see you short of breath. And so I have to set that instructional directive aside. And I usually say to a family member, well, tell me what you think they were meaning or feeling when they said this. What's the meaning behind what they said? And usually it would help me understand that this is that kind of person who would prefer more of a quality death experience than life prolongation at all costs. And so it's not that's not helpful. It's just that I have to put the instructional directive in the context of the current medical problem. And so that's what led me to say, well, why don't I just get people to measure in advance exactly the answers to the questions that will inform my treatment decisions when they present short of breath. That's that making medical decisions under conditions of uncertainty. So I'm not about advocating for instructional directives where older people say, I don't want CPR when I'm dying. I mean, they can say that. It's just not helpful. You got to realize it's not helpful to me. I need people to be able to express their values in the way that we ask those questions in PlanWell Guide or in my ICU guide. Look, thank you for having me. Thank you for having this conversation with me. I'm very passionate about trying to bring the needs and the voices of vulnerable older persons to the quality improvement table. I'm dismayed, to be honest, that healthcare system leaders, I don't think are very attentive to these issues, as evidenced by the fact that, you know, they have reports, they have dashboards, they look at a lot of quality indicators how long you wait in an emergency room, how long you wait before you get cardiac surgery when you need it. And I'm not trying to say these things are not important. All I'm trying to say is, why aren't these measures of patient-centered care, person-centered care, why aren't measures of quality end-of-life experience? Why aren't measures of adequacy of communication, of decision-making, of documentation, availability of documentation? Why aren't these things that are why aren't they being measured in our healthcare system? I believe measurement drives improvement. And so if you're not measuring something, if you don't look at it systematically, then you'll never be able to figure it out and budge the needle in improvement. Why does our healthcare system continue to allow this unwanted, non-beneficial care happen with no consequence? The example of that older person who spends 3 weeks in ICU and then dies, when, if you go back to the beginning, there was a value here that said comfort measures only. That scenario happens again and again and again, and there's no consequence. There's no recognition that that was a medical error. In fact, they don't use that word in our healthcare system. It's me, who has the information from the patient, and I know what truth is, so I'm able to say, hey, that was a medical error. And yet, the problems continue to perpetuate. And so to the extent that you're working in a space where you can, advocate for better healthcare for older persons, it involves, at an individual level, engaging people to do this kind of preparation for serious illness in advance. And again, those tools I mentioned are free, and they're informative, and it has what we call a Dear Doctor letter, which is the output of the planning. So the person's equipped with a crib sheet of their notes, so the things they have to say to the doctor in order to get an effective medical decision made. If you work in a legal space where you can help me reorient lawyers so that they're stopping making instructional directives and they're putting more emphasis on the capacitation of the named agent or substitute decision maker, that's another initiative. If you work in the healthcare system where you can advocate for the embedding of decision aids so that there's more capacitation of older persons or their proxies, so that they're better prepared to navigate that clinical decision-making space, again, that's a role and an opportunity. And finally, if you're looking at a systems level of looking at quality of care provided to older persons, where are those quality indicators that map out onto this conversation, and why aren't they part of what our healthcare system leaders look at? So I hope these things that I have said have been stimulating you to in the world or in the space that you work. I hope we can work together to continue to make the healthcare journey a better experience for the older persons that we all love and serve. Thanks for your time and attention.
Yeah, look, thanks, Daren. The key phrase that I've taken away from this is there's an increased appetite to lean into planning for serious illness.
Yeah.
And as civil society, each and every one of us has the opportunity to actually push this guide out. And from a personal perspective, I've started to use it. So it's easy, it's simple, and let's take this on as our collective responsibility. It's not a conversation that happens very often. We talk about end of life, but we don't talk about planning for serious illness. So thank you very much, Daren, and thank you also for getting up at 5 a.m. You look very smart for a 5 a.m. So thank you. Going forward, thank you to the IFA staff who are always on these calls, in particular Andra. Next week, after we've talked about leaning into planning for serious illness, we're going to pull back and listen to Dr. Peggy Edwards. And if you've ever listened to Peggy, you will know that at her very core, it's her role as grandmother to many grandchildren, but almost grandmother around the world. So she's going to come to us and talk with us about how our grandmothering's been happening in the context of COVID. So thank you all for being with us. And Daren, thank you very much. It was inspiring, and I hope every one of us on the call is going to take your messages away. So thank you.
Thanks. Bye.